Welcome, everyone. Thank you so much for joining us today. My name is Dr. Louise Ivers. I'm the faculty director at the Harvard Global Health Institute, and I'm really thrilled to welcome you to our Global Health Research and Innovation Speakers Series. This is our first event for this academic year, so we welcome everyone back into the mix. This monthly series is hosted by HCHI and designed to showcase the latest advancements in global health research, with the goal of fostering dialogue and elevating innovative solutions that advance health outcomes worldwide. So we welcome you today and to join us for timely discussions every month as we move forward through the academic year. We're delighted to be joined by Professor Barnabas today, and before I introduce her, I have a couple of notes. This session is being recorded through Zoom, and the recording will be made available on the HCHI website and our YouTube page in the coming days. We plan to have time at the end of the presentation for your questions. So if you have a question, you can use the Q&A feature on the bottom of your screen, and we'll do our best to get to those towards the Q&A session of today's event. So with that, please allow me to introduce our distinguished speaker. I'm thrilled to introduce her. She is a colleague and also a friend. Professor Ruanne Barnabas is a physician scientist and the chief of the Division of Infectious Diseases at Massachusetts General Hospital. As well as being a professor of medicine, she is a professor in the Department of Epidemiology at the Harvard Chan School of Public Health. Over the last 15 years, her research has focused on interventions for HIV and STD treatment and prevention, and recently also on COVID-19 prevention. She is the protocol chair of the CAN-SHE study to assess the impact of single-dose human papillomavirus HPV virus vaccination in Kenya. The ultimate aim of her work is to identify effective and scalable HIV, HPV, and infectious disease treatment and prevention strategies to increase access across diverse communities and promote equity in health. In addition to leading clinical trials and companion health economic modeling as an independently funded investigator, she also serves as an advisor to the World Health Organization and UNAIDS on cervical cancer elimination and treatment and prevention of HIV. She has many accolades and honors, including in 2020 being honored as a fellow of the Infectious Diseases Society of America. So with that, it's my honor to pass the microphone to you, Professor Barnabas. Thank you so much for being with us.
Thank you so much, Professor Ivers. It is truly an honor to be here, and I am grateful for the opportunity to share some of our work today. I will be talking today about the CAN-SHE study, and I love the name CAN-SHE because it asks the question, can she eliminate cervical cancer? And I'm thrilled to tell you today that the answer is yes. Yes, she can eliminate cervical cancer. I want to start by acknowledging and thanking the CAN-SHE study team and my collaborators, especially my co-PI, Dr. Nelly Mugo. It takes a real team of experts, and you can see some of them here on the screen, to conduct a study like this. So although cervical cancer elimination is possible, cervical cancer remains disproportionately the leading cause of cancer globally with high mortality. In 2020, there was just about 600,000 cases of cervical cancer and 340 deaths globally, with disparities in distribution. And I want to draw your attention to the high mortality associated with cervical cancer. More than half of incident cases result in premature death. Countries with effective programs are expected to eliminate cervical cancer. So a few countries, Australia, for example, is on track to eliminate cervical cancer in the near future. But you can see here in the dark blue colors, the countries where the burden of cervical cancer continues to persist, despite highly effective prevention and treatment strategies. HPV vaccines are highly effective at preventing cervical cancer. And I'm sharing the slide which shows the number of cases of cervical cancer among people who've received vaccination are just about 0.1 per 100,000 person years among people vaccinated younger than the age of 17. And there's a stark difference between people vaccinated here in green and people who are unvaccinated here in orange, where the cumulative incidence of cervical cancer is much higher. So these are the observed number of cases, and there are many countries, Scotland most recently, and others have reported actually 0 cases of cervical cancer where they have high coverage of HPV vaccination. And we know that HPV vaccination for all and catch-up vaccination to young adulthood can accelerate the time to cervical cancer elimination. And in this very nice modeling analysis from Kate Sims and colleagues, you can see here at our current rates we expect of screening and vaccination, we expect here in the red line for the numbers of cases of cervical cancer to increase over time. But if we're able to introduce screening and vaccination, and if we have vaccination for all, we're able to have a dramatic decrease here in the turquoise line on the number of cases of cervical cancer, and also bring forward the time to cervical cancer elimination. The WHO recommends single-dose HPV vaccination for all ages 9 to 20 and 2 doses above the age of 20. And this recommendation was made in 2022 based in part on the KENSHI study results, but also on other studies. And to date, more than 59 countries, actually I just looked it up, it's 70 countries today have adopted a single dose approach, and it's shown here on the slide, the countries where they have now moved from more than 1 dose to a single dose of HPV vaccination. I'm going to move on now to talk about the KENSHI study and the results, but I also wanted to highlight that the current coverage for HPV vaccination is about 20%. So we have a large goal to reach our target of 90% vaccination. So the difference between where we are, 20% of people who are eligible for HPV vaccination worldwide have received the vaccine, but our target is 90% of people. So we conducted a rigorous randomized trial, the KENSHI study, and found that single-dose HPV vaccination is highly efficacious, with 98% vaccine efficacy for HPV 16 and 18, which causes 70% of cancers. And I'll just walk you through the trial design here. We enrolled 2,275 participants in Kenya who were aged 15 to 20 and otherwise healthy, and they were randomly allocated to one of 3 study groups: immediate nonavalent vaccine, bivalent vaccine, or control meningococcal vaccine. And the endpoint of the study was incident persistent HPV infection that was type specific for these vaccine types among participants who were naive to vaccination at the time of randomization. The bivalent vaccine protects against 16 and 18, which causes 70% of cancers, and the nonavalent vaccine protects at an additional 5 high-risk types, which together those 7 high-risk types cause 90% of cancers, and also protects against type 6 and 11, which cause warts. Genital warts, also a cause of a significant morbidity among people with HPV. So here we have the study design, and I want to pause here to talk a little bit about how we came up with the study design. We worked very closely with our collaborators in Kenya and with very importantly, the Kenyan Ministry of Health. Kenya was transitioning from being a low-income country to a middle-income country, which meant that Kenya would need in the near future to purchase the vaccine under Gavi to be able to roll out an HPV vaccination program. And so this question about whether 1 or 2 doses was necessary to prevent persistent infection was of material importance. And importantly, they wanted to know the answer because this meant there were additional resources that they could use to meet other health needs, if indeed a single dose was proved to be effective as it did. So once we completed the 36 months of the study, we wanted to go on to assess the number of cases post the main study results, and I'm going to talk through how we did that. So participants who were enrolled in the study had specimens collected at the time of enrollment, and we excluded prevalent infection at enrollment and month 3. Participants were followed every 6 months, and physicians collected cervical swabs for HPV DNA testing. And if there were 2 swabs that were positive for HPV DNA 6 months apart, this meant the primary endpoint for persistent HPV infection. And we estimated vaccine efficacy at 36 months. We had very high retention throughout the study, 96% for 4 or more swabs. And this gives us confidence in the study results because we know there are few missing data. Participants who had prevalent HPV infections at enrollment were excluded from the per protocol or modified intent to treat analysis. And 29% of participants had evidence for HPV 16 and 18, and 52% had evidence for the 7 high-risk types 16, 18, 31, 33, 45, 52, and 58, and they were excluded from the primary analysis. I do have today also the efficacy among this group, which I'm happy to share if we get to it in our questions. And here are the results at month 36. You can see here in the blue and red lines the participants who received HPV 16 and 18 vaccination, and you can see here that the lines barely move above the x-axis. There was 1 case and 2 cases, very few cases in the vaccine group compared to infections in the control group. So here there are 72 infections over time for 16 and 18, and then for the 5 the additional high-risk types, so the group with 7 high-risk types, you can see here very few infections in the group who received vaccination, and 84 infections in the group that received the control vaccination. So this is very clear evidence that a single dose of HPV has very high efficacy, 98% and 96%, and that the lower bound of the confidence interval is also very high, just about 90% overall. So this gave us good confidence that a single dose is able to prevent HPV infection. The question then arose whether this impact of vaccination was sustainable over time. Could we expect to see over time a waning of the vaccine effect? We hypothesized that single-dose vaccination would be effective and durable over 54 months based on sustained antibody levels over 16 years. And these are data from two studies, one based in India, the IARC India study, and one based in Costa Rica, the CBT study. And here you can see over time, HPV 16 neutralizing antibodies in the dark blue and green lines. These are 2 doses or 3 doses, and here in this lighter blue line is the data from a single dose. And you can see here that while a single dose does have lower antibody levels, it is sustained over time up to 10 years here in the IARC India study and up to 16 years in the Costa Rica vaccine trial. So we expected that the single dose vaccination would be durable based on these antibody results. When we learned the result of the Kenshi study, we started quite quickly to cross participants over, actually before the planned end of the study at month 30 and month 36. So participants who were originally allocated to receive the intervention, the vaccine in the first randomization, were then crossed over to receive the delayed control, and participants who received the control vaccine were crossed over to receive the non-valent HPV vaccine. And we did this in a blinded fashion, so participants and study team members continued to be blinded regarding which vaccine they received at which time point. So everyone received an initial vaccine, and then everyone received a crossover vaccination. So I've showed you already the primary endpoint, which we measured at month 36. Then participants went through a period of the study where we started vaccinating, and then we completed vaccination for all participants, and we call this the crossover period. And then we have our final period where everyone now in the study has received a single dose of an HPV vaccine. And this is the all single dose HPV vaccinated period. And these are the new results that I'm thrilled to share with you today. I'm going to just spend a little time going through this figure because this is the format in which I'm going to show the study results, and I just want to be able to go through them. So this is the initial randomization 1:1:1 to each of these three groups: nonavalent, bivalent, or control vaccine, followed by the crossover period, in which time you receive the vaccine that you did not receive at randomization, and then finally up to month 54, where everyone has received single dose vaccination. And we're going to look at two things. We're going to look at the durability over time, and we're going to also look at whether there's any waning in the efficacy of the vaccine over time. And so I'll be presenting results now, new results from the crossover period and the all single dose HPV vaccinated period. So I showed you the final endpoint results, and then we're going to show you crossover and all single dose at the all single dose period. And I'll just talk through the specific aims that we had for each of this and the analysis strategy. So to evaluate effectiveness of single dose HPV vaccination for 18 to 23-year-olds, we compared the cumulative incidence of persistent HPV using Kaplan-Meier or cumulative incidence curves, and the incident rate estimates for the immediate and delayed vaccine groups. And this is a graphic illustration. And also I'll show you numbers and I'll show you figures that illustrate the difference in cumulative incidence. And then to assess durability, our second outcome, we used Cox regression modeling, and we accounted for time and time variable cofactors. So for example, we were able to account for time since vaccination. And the endpoint here was incident persistent type-specific HPV infection measured at 2 time points 6 months apart, as we did for the primary analysis. And both analyses used the per protocol or the modified intent to treat cohorts. There were no differences in baseline characteristics between the study groups, and participants were aged 18 to 23 years at crossover vaccination. And so this is just showing that the groups remain comparable, as there were no differences observed at the time of crossover vaccination. Retention continued to be high. It was 90% for 3 or more swabs, and the median time between swab collection was 6 months, so almost exactly what we aimed for. So this is all credit to our excellent study team. And for 5 or more swabs, retention was 91%. Just about everyone received crossover vaccination, 95%. And the median follow-up time was 53 months. So we have complete data for which to do these analyses. I also want to share the incidence of persistent non-vaccine HPV types. And this was stable across time periods and between the study groups. And this indicates that there was continued HPV exposure. So nothing about behavior was different between the groups, which helps us interpret the results. So this is just showing for HPV types that are not included in the vaccine, that are not the high risk types, as we know, in the non-valent vaccine covers 90% of high risk types for cancer. And you can see here very stable non-vaccine types, just about 20 and 22 across the different periods, and importantly between the study groups. And so now I'll move on to showing the durability and vaccine efficacy results. And so these are the results showing time all the way out to month 54. And I'll start here in the blue line with the group that received immediate HPV vaccine, and these are both the bivalent and the non-valent vaccine groups here together. And you can see that the line barely lifts over the x-axis, just 4 cases pre-crossover and 4 cases post-crossover. And then, and you can see here the cumulative incidence very low, all below 1 across all 3 periods. And then when we look at the group that received the control group, you can see the number of incident cases of persistent HPV increasing over time. And you can appreciate that this really slows down once participants had received single-dose vaccination. And once everyone is vaccinated, here over the end of the crossover period, you can see the line is pretty flat. And you can see that also reflected in the cumulative incidence, 16, 20, and then holding steady at 20. So providing the single dose of HPV vaccination up to age 23 really leveled out the number of new cases of incident persistent HPV infection. And this is showing the incidence of persistent infection over time here, keeping the same color scheme. In the blue line, the group that was vaccinated immediately. In the red line, the incidence decreasing with crossover vaccination to be comparable to the group vaccinated early. And then just in gray, the background of the non-vaccine types. And then zooming in so you can see very clearly that incidence really falls once we're able to vaccinate people. This is the result of the Cox regression showing the vaccine efficacy over the 54 months. And here the modeled vaccine efficacy at 54 months is 99.2% with a very tight confidence interval, the lower bound of which is 96%. And this is for HPV 16 and 18. And I'm going to move on now to showing you the results for the 7 high-risk types in the non-valent vaccine. And sorry, just zooming in first to show you the details here in this graph. So for the 7 high-risk types, you can see here again for participants who are vaccinated immediately, a very low number of cases, 5 and 5 pre and post crossover. And once we look at the group that received the control vaccine, once they're vaccinated, you can appreciate again the slowing down in the number of cases. And then once everyone is vaccinated, a real leveling off post crossover. And you can see that also reflected here in incidence. Once everyone is vaccinated, the number of new cases plummets in keeping with the vaccine efficacy observed. Here again, showing incidence among the group vaccinated early and late, that dramatic drop in incidence with background staying the same. And here zooming in so you can see the detail. And then here again for the 7 high-risk types, looking closely at the Cox regression analysis, a estimated vaccine efficacy for the non-valent vaccine of 98.9%. And this is sustained over time without evidence for waning immunity. And then zooming in so you can see that the confidence interval is still very tight above just about 95%. So in summary, we found that single-dose HPV vaccination effectively protected adolescent girls and young women from incident persistent HPV infection over the first 54 months post-vaccination. The study had a rigorous design. There was high fidelity to the protocol, high retention, clear ascertainment of outcomes, and this provides strong evidence for single-dose HPV vaccine efficacy for age up to 23 years. Single-dose 16 and 18 and 16, 18, 31, 33, 45, 52, and 58 vaccination had a lower bound of efficacy, more than 94%, and this is in keeping with licensure trials for 3 doses without evidence of waning. And we know that in a formal clinical trial, single dose, 2 doses, and 3 doses have the same effect. That was through the Escudo trial, have the same effect on persistent HPV infection. HPV vaccination confers high protection once infections prevalent at vaccination have cleared. And this is an insight from exploratory analysis. And I have those slides as backup, and I'm happy to show that to you today during questions. And this adds to the growing body of evidence supporting the efficacy of single-dose vaccine efficacy. I want to highlight here also that the group who were enrolled in the study were aged 15 to 20 and then 18 to 23. And this is the group of participants who are at high risk of acquiring the infection today that will cause their cancer in 10 to 12 years. And so these data support a paradigm shift in how we think about vaccination, thinking about expanding vaccination to include not just 9 to 14-year-olds, but also older, up to age, in this study, 23, but there have been other studies up to age 26. I want to also share some data from Grace Umatesi, a brilliant postdoc in our group who works on cost effectiveness modeling and implementation science and many other things. But here's her paper looking at the cost effectiveness of single dose. And you might ask, why do you need to do an analysis? Isn't it obvious that single dose is more cost effective than 2 doses? But there was a paper published showing a different conclusion. So we had to do the rigorous analysis to examine this question and publish these results. And you can see here that a single dose is more cost effective for cervical cancer prevention than a multi-dose approach. And then we were able to model different strategies, including multi-age cohort and catch-up vaccination. And that turned out to be the most cost-effective because it decreases the number of cases quickly and in the short term, so we can more quickly see the impact on cervical cancer. And you can see here in these blue dots, the return on investment for single-dose vaccination outperforms other strategies for multiple doses. So a suite of studies demonstrated high efficacy for single-dose vaccination. The WHO changed its policy recommending single-dose vaccination in 2022, and these data can extend those findings to ages 18 to 23 and durability over 54 months. Since the WHO changed its guidelines in 2022, more than 12 million girls who otherwise would not have been vaccinated have received a single dose of the HPV vaccine. And this is, a result of a large number of people moving forward with implementation science, which is really what we need to do for the next steps in the study. I want to end the talk focusing on the perspectives of patients. And this is our 12-year-old daughter, Dadiba, who received a single dose of her HPV vaccine in November of last year. And in April this year, we faced the decision whether she should have her second dose. And we, and based on the evidence and through shared clinical decision-making with her pediatrician, we decided that the benefit of single dose was high and there was really little to be gained by a second dose. And so she has received a single dose, and we spent the time baking, which is one of her favorite things to do. When I was on service earlier this year, I saw a patient who was in her early 20s when she acquired HPV that resulted in cervical cancer. I saw her recently, now in her mid-40s, with complications of infectious complications of cervical cancer. And I really wish that we could have taken this extra dose of vaccine and go back in time and give it to her, because almost certainly she would not be on the inpatient service had she received a single dose of the vaccine in her 20s. The Kenshi team is incredible and enormous. I want to thank everyone on this slide who has worked very hard on the Kenshi study since 2018, and we're thrilled to be able to present updated results from the study. I'm very happy to take questions, and I will stop there. Thank you so much for your time.
Thank you so much. I really appreciate that. And you went through a lot of the data and the explanation, and we do have a few questions coming in, so I'm going to turn to the ones from the audience. I'll start with a question specifically about whether the participants in the study had their HIV status collected. And if so, was the uptake and durability different between those living or living without HIV?
Great. Thanks so much for that excellent question. One of the things we were able to do during the study was to provide comprehensive sexual and reproductive health services. So participants received STI and HIV testing every 3 months, and they also received PrEP and STI treatment. We had very few incident cases of HIV in the study. Unfortunately, they're too small to see a difference in efficacy, but efficacy overall was very high, and that is also holding, but it's not enough to give us a definitive result. So actually, to answer this question, we started about a year ago a new study, HOPE to evaluate single dose HPV vaccine efficacy among people living with HIV. It's a very important question because of the synergy between HIV and HPV. The burden is very high in high HIV burden settings. So we are very keen to know the answer to this question, but we were not able to ascertain that in the KEDSHE study.
Thanks, Ruanne. So there's two questions that are a little bit about the same thing, which is about uptake, and maybe I'll pose them in two ways. One is about studying the factors around hesitation towards HPV vaccine, and does more work need to be done there? And another is a question from a colleague in Ghana who's saying that Ghana prepares to vaccinate girls aged 9 to 14 this September. And are there practical lessons from the study, the KEDSHE study, and Kenya's experience for high coverage and high community acceptance, etc.?
Great, those are excellent questions, and I'm thrilled to refer you to Grace Umutesi's implementation science paper. I didn't go through those results today, but she did conduct qualitative research. And one of the most important lessons from her research is that, and actually it's true for vaccines across the board, that recommendations from physicians supporting vaccines are highly valued. And so I think we can't miss that communication step, how important it is to communicate that they're valued. It's why I'm sharing Didima's vaccination status, and I hope that we can have these conversations with patients and community members in order to increase the reliability of the information that people have to make decisions about vaccines. Grace's paper was published in March, and it should be you should easily find it now. I will pass it on so that it's available with the records from this talk.
Yeah, great. Thanks. What we can do is add it to the notes for our YouTube channel. Great, thanks. A question, a methods question or analysis question. So if there's an analysis of the per exposure effect of the treatment, since the design is crossover, is there a depletion of susceptibles in the group being crossed over that somehow impacts your results? Is that question clear to you?
Yes.
Yeah, great.
Yes, absolutely. So it's a great question because you would expect that once that the incidence in the group that was vaccinated later would fall, and so we might not have adequate power to see an effect of the vaccine, which is why we looked at the incidence of the non-vaccine types and showed that it was pretty steady throughout. So we think that there's no change in exposure. And then we have, of course, observed the number of cases up to the time of crossover vaccination. And so we think that there's not a change there's not a depletion of susceptibles due to the exposure to the non-HPV vaccine types. And we seem to be adequately powered given the tight confidence intervals as well. So that's a great question. And if I may, I'll just take it one step further. There's actually a really nice paper that came out of a Canadian group last last year, where they try to evaluate for among people who have cervical cancer, when did they get that HPV infection? And they have demonstrated that the causative infection is up to age 26, which just further builds the case for, and actually it continues up to age 45. There's still some number of cases where people acquire the HPV later, but still we expect to see a benefit of the vaccine even unto older age groups, because when you look at when did you get this HPV that is causing the cancer, it's not just early on in childhood, it's at any time during the sexually active life.
Thanks, Ruanne. Can you speak a little to the data, if any, on single dose effectiveness in males?
Yes, so this was great. The WHO is very keen on having lots of data for women, and there was a study conducted, the DEBS study, where they did look at antibody levels among boys. Boys actually have higher antibody levels than girls, so it gives us confidence that single dose among boys works just as well as more than one dose. And so the WHO recommendations are for boys and girls up to age 20.
You spoke at the beginning of your talk, or as part of the context, that there's a big gap between those who've received vaccination and the target. And then you shared with us about the estimate of how many additional people may have been vaccinated with this policy approach of a single dose. Can you reflect a bit on your thoughts on how we're going to meet that gap, and the various barriers there may be? I know this is beyond the specifics of the research, but obviously as an advisor to WHO and UNAIDS, like, you're very aware of the barriers that countries are facing or communities are facing, and I'd love to get your thoughts on that.
So great question, Louise. Certainly the cost of the HPV vaccine has been a major barrier to scaling it up and making it widely accessible. The cost in the US is about $300 for the full series, and most vaccines that are part of early childhood immunization programs, for example, are around $1 or less. So there's just an enormous difference in cost. As a result, many companies are working on lower cost vaccines, and Sequelin is actually a already WHO approved vaccine that is 2 orders of magnitude less expensive than the existing commercial vaccines. And so this I think will be a really critical part in scaling up vaccines, making it much lower cost, making it more accessible. And then I can't resist but sharing that when you look at fractional dosing for HPV, because the vaccine is so highly immunogenic, even in the original FDA filings, when they do dose escalation, you can see that even a fraction of a dose is highly immunogenic. It's not been tested with these with these disease outcomes, but I think that if you really wanted to scale up, in addition to making lower cost vaccines, a vaccine could go further. And in emergency situations, we do fractional dosing for vaccines, as we did for Mpox here in the US. So that is something that we could also think about.
Thank you. And you had very high uptake and very high follow-up in your study. And generally speaking, HPV vaccination has been welcomed by communities and by women and girls and boys as it's rolled out. But are you seeing any change in that as it relates to the degree of vaccine hesitancy that's emerging in other areas, or as it relates in the US to what's happening with our health system and the director of our health system being such a skeptic of vaccines? Is that impacting HPV, Ruanne?
It's such a good question, and of course, I think at some level it is, but I believe it is a challenge that we can rise to. When we started the Kenchi study in Kenya, and we would visit with communities and ask in any room, does someone here know someone who has been impacted by cervical cancer? Many hands would go up, a third to half the hands in the room. And I think how near the impact of the disease is, and that it affects women in midlife and affects their families and communities is something that is very much a reality, and that's helped with HPV vaccine uptake. And I think we have a lot of work to do to understand that when we no longer see that as part of our everyday reality, that the vaccines will continue to be important. And of course, that said, for HPV, we could actually get to a stage where we have, just very low prevalence, and then we only need to vaccinate 9 to 12-year-olds. And so also communicating that infectious diseases are dynamic and they change over time, and what we do over time might need to change as well, but we can do that through partnership and collaboration.
Yeah, I mean, you're setting a bold vision there, and I know, as you mentioned also, that Australia is on target to eliminate cervical cancer, and some other areas are taking it on. Like, it seems like we're quite a ways away to get to that goal where we're just vaccinating periodically or cohorts.
Yes.
But I appreciate your vision of that. Do you think it's going to be a reality, or how long will it take us to get there? Like, what are the projections for that?
Yeah. So the projections are quite far in the future, 50 years or longer. But there are definitely things that we can do to make it a much more seamless approach. So, for example, if we are able to do both screening and vaccination at the same time, screening and treat current infections, vaccination to prevent future infections, this is a strategy that has the potential to have a high impact in a short time. Most infections actually clear spontaneously as well. So I think that's the other advantage that we have, is that the natural history is on our side. And we are, and several countries are reporting 0 or fewer cases. Sorry, can't get fewer than 0, but a very few cases overall. And so I am cautiously optimistic that we could get there despite the kind of many obstacles and barriers that we face currently. It is as simple as it could be, a single dose, and it is as highly effective as it can be, kind of 99%. And it's something it's easy to wrap your head around and understand what needs to be done, and hopefully we can do it.
Well, I was going to ask you if you had any closing comments, but I think you've just said them. It's as easy as can be. It's as straightforward as it can be. We know what to do and it can be done. And I think that's a very positive message to wrap up. Thank you so much, Ruanne, for such a wonderful talk and sharing your research and your team's research with us. Congratulations for everything you've done so far. And we're looking forward to see how it continues to advance. Thanks to our audience for joining us and for your engagement with many questions that were both technical on the details and high level on policy. We appreciate you and look forward to seeing you online next month at our next session. Thank you so much.
Thanks, everyone. Bye-bye.